Hello, everybody, and welcome to another episode of Mind Matters, Navigating Head Injuries and Concussions. I'm your host, Kiley Como. I'm the legal nurse consultant here at Shane Smith Law, and today I'm speaking with Dr. Mackenzie Lerario, a medical doctor specializing in neurology, as well as a researcher, a published author, and speaker. Dr. Lerario, it's great to speak with you today.
Thank you for having me. Exciting to be here.
Great, awesome. So if our listeners out there, our viewers, if you've tuned into any of our Mind Matters episodes before, then you know that our focus here is to really dig into all things traumatic brain injury, brain related. So with that, let's dive in, Dr. Lerario. Could you maybe tell our listeners a little bit about yourself and what you do?
Sure. I am a neurologist. Recently relocated to Philadelphia to start a job position at Thomas Jefferson University. I'm an associate professor of neurology. As well, I have a full clinical practice handling all kinds of general neurological issues. I'm also boarded in vascular neurology, which is a stroke specialist, and I have a very specific interest and experience treating functional neurological disorder, also known as FND.
FND, right. And so I think for our listeners, this is going to be a two-part podcast. So in this first part, it's my understanding we're going to dig into that FND. So I'm excited to pick your brain, no pun intended, on that. So let's get into it. So being that one of your areas of expertise is that functional neurological disorder, or FND, let's talk about it. What is FND, and what are maybe some of the common misperceptions of what that is?
Yeah, that's a good question because when explaining FND to patients, I kind of have to describe both what it is not and then also what it is. And unfortunately, there's been a lot of misunderstanding over the years as we've come to describe and know what this disorder is, as we had developed new brain imaging techniques that are more advanced to better understand what FND is. So this diagnosis kind of had its roots many years ago in the term hysteria, which people may be more familiar with. And then in Sigmund Freud's time, it was changed to the name conversion disorder because people at that time thought that there were psychological stressors that were being converted into neurological symptoms. And now we call it functional neurological disorder. And functional, just to explain it by each word, functional is describing brain networks that are malfunctioning. And this is in contrast to structural neurological disorders where we see damage to a specific part of the nervous system, like there's a stroke or a tumor that's damaging the structures of the brain system. And in FND, we don't see that on any of our testing. But if we do advanced neuroimaging using functional MRI, we can see that there's actually malfunctioning of very important brain networks resolved for sensation, incoming information into the brain, and then motor output and how that's integrated. So with that malfunctioning, we like to kind of make the comparison, the analogy to computers by saying for structural neurological disorders, it's like the hardware is intact versus for functional disorders, the software is malfunctioning. So there's really this miswiring between the brain and the body, sending these abnormal signals to each other, and it creates a whole host of neurological symptoms. So I have patients who have seizures that are not epileptic. If we put in EEG on their head, electroencephalogram, and measure their brain waves, we see that there is no abnormal electrical discharges. I've seen people with weakness or difficulty walking or tremors or tics, trouble speaking. All of these things could fit under this larger umbrella of FND. So that's, there's a kind of a varied presentation of how people can develop this disorder and what symptoms they can present with. And it's quite disabling, to say the least.
Yeah, that's one of the things I was looking forward to hearing about the FND. It sounds like an overarching, you call it, I think, an umbrella term. A lot of our own clients that come in suffering from a motor vehicle accident or a blow to the head, or sometimes there's not even a direct impact. It's that just that sudden deceleration stoppage, coup contra coup injury, where you have some of those internal injuries, whether there's direct impact or not. It sounds like there's a lot of crossover with some of that, the anatomy and some of the symptomology. Would you say that's correct? Would that kind of fall up under those functional neurological disorders?
Yeah, I think that would make sense. After concussion or other head injury, the functioning of brain networks can be disrupted as well. And we also see with this disorder that injuries can precede the development of the symptoms and the onset of symptoms. And it's not a direct cause, but there's an association. And we do see sometimes people who have trauma before they come to present to our offices for treatment.
Interesting, interesting. So you talked about some of the brain structures in there. And I know, again, to some of our viewers and listeners, we do get into some of that brain anatomy. So I'd love to, being such an expert in the field, talk about some of those brain structures that might be involved with FND.
Yes. So outside of the parts of the cortex and brain that are involved in integrating and processing sensation and motor output and coordination, there's two other important structures I think that are connected to this that are important. Actually, I'll say three other structures that are important in the pathophysiology of FND and what it is. One is the right temporoparietal junction. That's the right side between the temporal lobe and the parietal lobe, kind of where I'm pointing right now, around where the ear is, and then closer to the top of the head on the side. And what we see is that area in people with FND is under functioning, it's hypoactive. And that part of the brain is in control of how voluntary movements feel to a person. And so if it's not being activated appropriately, it's actually showing that a lot of these symptoms are out of the control of the person who has FND. So they're not voluntary. And the reason why this is important is because of this previous misconception that these are psychological symptoms or solely psychological symptoms. There's been a lot of stigma attached to the disorder that patients are faking it or making their symptoms up or things along that spectrum. And that's really not the case. It's out of their control and they're not obviously faking it and it's not all in their head. But what we do see is that the brain structure called the amygdala, which is part of our limbic system, and that's responsible for processing stress and emotions. That's like on overdrive in people with FND. It can be larger in structure and more active in functioning in people with FND compared to those without. And that's been found on imaging studies. So that I don't think, again, is a cause of FND, but it could sensitize a person to develop FND, that their brain functioning is one that's sensitive to stress and emotional events. And we do see that there is a large association between previous physical and sexual abuse and other types of emotional abuse and things of that sort that is more common in people with FND. And so, it's still unclear exactly how this all correlates, but because physical and sexual abuse is more common in women, we do see that there is a 3 to 1 times increase in FND in women compared to men. And we also think there could be biological associations with hormones. And it's still unclear why that is, but there is some signal that emotional and stress processing could play a role in the development of symptoms, but is not causal. And then last, how our body pays attention to neurological symptoms, our attentional circuits, which include a part of the brain called the anterior cingulate cortex, which is kind of in the center front of the brain, deep inside the brain, and then more so on the outside, what's called the insular cortex. And these are part of the network responsible for attentional processing. And what we see with FND is the symptoms are actually influenced by whether or not we're paying attention to them or distracted. So when a person is finding that they're paying more attention to their symptoms, they could actually worsen. And if they're distracted from the symptoms, they can actually improve. As an example, if I'm examining somebody with FND, say with a motor symptom like a tremor, while they're having that symptom, if I have them do something else, like tap their foot or open and close their hand, that tremor can actually change, either improve in its intensity or frequency, or even what we call entrain by going in the same time as whatever the hand or foot movement is. So it kind of changes in its character to match what the distraction task is, like opening and closing your hand or tapping your foot. So all three of those areas, the how voluntary it is with the right temporoparietal junction, the amygdala with stress and emotional processing, and then this attentional circuit, including the anterior cingulate gyrus and the insular cortex. These are all important in the pathophysiology of FND and what's happening in the brain in people with FND.
That is fascinating. I especially am intrigued by that attentional circuit component you mentioned. I think we stress a lot to our clients that seeing a specialist, especially when you're talking about traumatic brain injury, concussion, is such a key step in getting good treatment, because no shade against primary care physicians or whatnot. They're just not trained as in depth as someone like you may be, and so may miss some of those sorts of things. Tag something as like a pseudo symptom versus a very real symptom of a deeper issue. So really appreciate you bringing that up. You get me thinking though. You're talking about not necessarily causality with some of this stuff. What are there any specific causes for FND? Can you tag that?
We don't entirely know the exact cause of it, so that's still trying to be elucidated at this time.
Okay.
But what you were saying about primary care doctors is and other providers and even neurologists are just not well trained in this disorder.
Yeah.
And it's the second most common reason somebody visits an outpatient neurologist like myself. So it's actually not uncommon, it's just lesser known. And with the misinformation out there and the lack of training, there can be some insensitivity and just an inability to provide the most specialized care by many providers. And that's not just primary care, but that's even a lot of neurologists as well.
Yeah, you're 100% right. That's a good call out. We have advised some of our clients to that degree as well. Not all neurologists or anything. They're very specialized, fields of neurology themselves. Not all the same. So, very important point to make. Thank you. So, how do you go about diagnosing FND? There's no known really pinpoint cause for it. How do you diagnose it then?
Yeah, so I think that's also a major change that happened recently in the last 10 years with the change from conversion disorder to functional neurological disorder, with this updated understanding of it. So in the past, it was something where we tried to rule out other causes of neurological symptoms. And if we ruled out everything else, then we could make this diagnosis of exclusion by saying what it is not. It is not a structural neurological disorder. But now we're trying to refocus that. While there might not be any visual abnormalities on imaging techniques in FND, what we're trying to do is not say what it is not. We're trying to rule in certain signs on examinations or symptoms that are being expressed in the patient's history that rule in the diagnosis. As an example, in terms of like, say, a patient providing history to us, with an epileptic seizure, if somebody was to have generalized body shaking convulsions, they would lose consciousness because that's diffuse electrical discharges throughout the entire brain, and a person can't maintain their consciousness during that. Mm-hmm. With FND, a person could have whole body convulsions, but still maintain consciousness, remember things that are happening, interact with their environment. And that is, a sign that this is more likely due to a functional disorder than a structural or epileptic one. Signs on examination, one could be the example I provided before about the distractibility improving the symptoms, or the entrainment, where, say, example, a tremor could then start moving in time with a distraction task. and change its characteristic in a way where it shows that it's not consistent as the patient is doing different types of physical exam maneuvers. There's also ways, for an example, a well-known neurological test called the Hoover sign, which assess for functional weakness. As an example, you would have the patient lay on their back, stretched over the bed on their back, and you ask the person to extend their hip, which is to push their leg down into the bed. And if a person's weak in that leg, what we would tend to see is the other leg, the hip would be raised off the bed to compensate for the weakness if the person's really trying to push down and has the ability to do that. But in FND, we would not see the non-weak leg raise. And so therefore, we would diagnose that weakness of the weak leg and that inability to extend the hip, push it down into the bed. That would be functional in nature. And so that sign is actually quite good for detecting functional weakness, at least in the lower extremities.
That is fascinating. We talked to a few neurologists before, and there are so many ways to diagnose, so many batteries of assessments. I mean, to keep up with all of the latest, most innovative techniques, it's got to be a day-by-day endeavor, I would think, in some of these things. So that's a fascinating stuff. All right, everybody, that is going to wrap it for another episode of Mind Matters, Navigating Head Injuries and Concussions. Once again, I'd like to thank today's guest, Dr. Mackenzie Lerario, for joining us today and sharing their knowledge, insight, and passion with us. You can find Dr. Lerario practicing in the Philadelphia area, as well as in several published articles in various scientific journals. I hope that our audience has enjoyed this enlightening and thought-provoking discussion and is leaving with a deeper understanding and appreciation of the exciting and innovative work being done to better understand and treat functional neurological disorders. Please don't forget to hit that like button and subscribe to our channel so you can keep up with our newest content. And also, leave us a comment and let us know what you thought of today's discussion. And as always, remember, if you're in pain, call Shane at 980-999-9999. Thanks for watching.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.